Welcome to the Equality, Diversity and Inclusion in Health Psychology podcast. My name is Dr. Jal Mayam, and I am the producer of a series of this podcast where individuals will be invited to share their thoughts, insights, and experiences. This is to help our discipline in the field of health psychology and to provide solutions for the future. I hope you enjoy this podcast, and if you have any questions, then let us know. And if you want to interact with us, then there's lots of contact details in the details inside the description. So should you need to get hold of anyone, feel free to do so. In the meantime, sit back and enjoy this podcast.
Hi everyone, I'm Kiran again. I'm from the Division Health Psychology EDI task force, but I won't be. This is just a normal conversation, and I work in a trust and a few other bits and bobs. But what I say today is representative of my thoughts as an individual rather than as a representative of any other organisation. And just to say, I am an Asian woman with so long brown hair, and my pronouns are she and her. And then I'm going to introduce my guest for today. Over to you, Victoria.
Hi everyone, I'm Victoria Clarke. I am an Associate Professor in Qualitative and Critical Psychology at the University of the West of England in Bristol. And again, just to put the disclaimer that the views I'm expressing today are my own opinions, are not representative of those of my employer. I am a middle-aged white woman. In terms of visual description, I'm wearing purple glasses, got copper hair, got a bright orange jumper on, and I'm sitting in front of a very, very busy yellow bookcase. And my pronouns are she, her, and they, them.
That was so much better as a description than what I said.
I've done it before, so
yeah, definitely learning today. Yeah, I just wondered if we could start with thinking about, your journey with disability, and then we can think about what health psychology and ableism, and thinking a bit about what kind of things might be helpful to change. So shall we get started? Do you want to take it away? Yeah.
So my experience with disability has kind of changed over time, and I think I've only really properly started to understand it relatively recently in terms of the social issues around disability. So as I said to someone once, you don't get like a guidebook when you become disabled, and you don't magically stop being ableist. So I was kind of legally classifiable as disabled when I developed chronic fatigue syndrome around 2006. I had a year off work. I mean, literally, I woke up one day, got downstairs, couldn't move, sat in a chair for the rest of the day, couldn't move. It was obviously scary, frightening, terrifying, and all the rest of it. Tried all the wild and wacky cures and treatments on offer because mainstream science and medical care didn't really have anything to offer, and that got me back to work, but I lived with that invisible chronic illness. Well, I still, as far as I know, I still have it, but other things have happened to my body that have kind of trumped it. And I thought I was a kind of lefty-leaning, social justice-oriented person, but I didn't really understand what it meant not to be ableist, and what the social kind of exclusions and structural oppressions were around kind of disability. Like many people with an invisible illness, I hid it. I didn't talk about it. I got upset if I was put in a position where I was forced to disclose it. And I tried to kind of present as, normal and well and healthy and all those things. And then that rapidly changed pretty much overnight when my body started doing some very strange things. I thought it was the chronic fatigue syndrome, because if you have chronic fatigue syndrome and your body starts doing strange things, you just immediately assume that's what's happening. But I was eventually diagnosed with MS in October 2019, and in a period of months had gone from pretty much full mobility to really limited mobility. So in multiple sclerosis, there's a scale for measuring disability, and I'd gone from 1 on the scale, which is, you know, almost completely fully mobile, to a 6.5 or a 7, which is classified as severely disabled. So I lost
Quite
kind
a
of
lot of a change.
yeah, it was very rapid. It was very quick. It happened on campus, bizarrely. I was climbing up a flight of stairs to go to a classroom, and then just literally trying to lift my leg up to go up the next stair, and it wouldn't lift.
My goodness.
And it was just like, it literally happened in that moment when I was kind of on campus. And then my mobility from that point very rapidly deteriorated. So I seem to have a progressive form of MS, but if anyone specializes in MS, they will know it's like, I mean, I naively thought there was relapse remitting and primary progressive, and they're two really neat categories. And it's like, no, there's about 20 categories, and we're inventing new ones all the time, and we don't really understand it. So I don't really have a clear diagnosis. And there's also lots of ambiguity around diagnosis from the perspective of MS specialists, so neurologists who specialize in MS, because medications are approved for certain kinds of MS and not others.
Right.
So they're not going to diagnose you with the kind that there's no medications approved for, because they want to be able to do something for their patients. So there's this sort of ambiguity around diagnosis where we sort of know my MS is progressive, but I don't have an official diagnosis as secondary progressive, because there's no medication if your secondary progressive MS is inactive. So it's this
Bit of a
really
vicious
kind of,
cycle that
yeah,
as well. Yeah.
it's a very kind of odd space. But it was I mean, it has been a rapid learning in terms of what it means to be physically disabled, in terms of having limited mobility, being a wheelchair user. I reflected a lot on how ableist I was in my thinking, and it's because I didn't know. And I think my friends who I've spent a lot of time with would say the same as well, that, you know, they thought they were nice, kind of lefty, social justice oriented people, and then wham, all of a sudden navigating the world in a wheelchair, and the world looks incredibly different. It's really exclusionary. You feel like a second class citizen because the world is literally not designed for you. And so it was a rapid learning process. And I just decided fairly on, I could either beat myself up and feel really bad about how ableist I was in the past, or I could put my energy into trying to learn and to accept that I don't know everything, and to try and help other people to learn as well. So that's what I've decided to do. So I'd say to anyone listening, if you're feeling bad and thinking, oh God, I don't know about this, I don't do anything about this, I think that's normal, because that's what society facilitates, is an ignorance around disability. You only really get to grips with it if it is in your kind of personal experience or the experience of someone that you're close to. So I wouldn't feel bad about that, but I would try to think about, well, what can I do to make a difference? Because there are things that you can do without putting lots of energy into things, but there are accommodations that do take work and time and education and learning, and I think we've got to be honest about that. That it's not just a case of combating ignorance, it's also a case in some instances of resources and stuff like that. But that's a very long answer, so I'll stop there.
No, it's absolutely, really, there's a lot that I want to pick up there. But it does resonate with something that I was saying quite recently about how it was a quote that I had listened to a podcast where they had talked about being in a systematically racist society, and if you're in a systematically racist society, then it would be surprising if you didn't end up absorbing some systematic racism. And that kind of takes a little bit of the pressure off an individual to kind of take full, the weight of that, which is something that our society can also encourage people to do, and would argue that it's similar for other forms of oppression, including ableism. And speaking from experience of working with people with epilepsy, there was when you look at the surface of it, there's a few different types of seizures that people can have, but then when you look into it more deeply, there's about 148 different types of seizures that people can have, and lots of things around not quite knowing when it might start, when it might stop, what might the triggers be, or, why some people respond well to certain medications and why others really don't, or why some people have very few side effects and other people don't. And just also thinking about the chronic fatigue syndrome of 2006, there was hardly anything. It's been only recently that, for example, that's changed in terms of recommendations and NICE recommendations, all the things around that. So yeah, really resonate with what you're saying, and working closely with disabled people over time, got to see some of the issues that people face on a daily basis, but without that experience it would have been difficult to actually witness it. So can relate to that. So I suppose thinking about that, I work in practice settings, and one of the things that we talked about was about advocacy. And interestingly, I said, what's one thing that all the people that we work with share, because we've done a lot around anti-racism for specific subgroups, but it's not something that we thought about, and colleagues had struggled to really visualize what I was trying to say. And it was like, we work in a hospital, we work with people with chronic illness and disability, who and I just found that my colleagues, oh yeah, we do. And it was so ubiquitous that we hadn't really thought about it specifically. And I just wonder if that's something that perhaps people who are listening can relate to when they work.
Yeah, and I mean, I think that's certainly been a revelation to me. Is my sort of working assumption would be that hospitals would be good with disability.
Yeah.
Because it's sort of their bread and butter.
Yeah.
It's they work with disabled people every day, but they're not. And that's been a real shock. And I've written so many letters of complaint to Gloucestershire Royal Hospital. I'm sure the chief executive has got rather fed up of seeing letters with my name on if she gets to see them, because just really basic stuff like the waiting areas are not laid out for wheelchairs. So the waiting area for the MS clinic, you can't get a wheelchair in it. You can't get I always pronounce this wrong, even though I've been using one for years. Rollator. I think it's rollator. You can't move around with a rollator in the space because everything's so tightly packed. And they don't have, the only place I've been that has chairs with arms, the kind of, I call them the sort of care home chairs, the physio clinic. Everywhere else doesn't have them. So you're sitting in a MS clinic waiting area. You can't get in with your wheelchair. So I can transfer. So I go and sit in a seat, but there's no arm, so I can't propel myself out the seat. And I'm thinking, surely in a hospital, this stuff should be sorted. This stuff should be considered in design and so on. So I think if you work in a hospital setting and you look around the space and you think about, well, is it wheelchair accessible? Is it accessible to somewhere in a rollator? Is there something I can do to change the space to make it more accessible? That would be wonderful, because hospitals are really hostile places if you're disabled. I would go as far to say hostile, because they're just, ironically, they're full of people in wheelchairs, but they're not designed for people in wheelchairs. So I had an MRI recently, and I can't get on the the flat bed for the MRI. I can't get on and off it independently.
Right.
The technicians aren't supposed to help you for health and safety reasons, which is fair enough. So what do? You can't get on the bed. They're not supposed to help you. I mean, luckily, the technicians that were on duty on the day were of the very relaxed and laid back kind, and we'll help you, and just tell us what you need, and we can move this and lower this and all the rest of it. But I have been on some occasions, and my dad, who's gone with me, has had to sit in the room to help me on and off the bed because the technician won't won't do it. And it's like, this is a hospital.
I mean, it would be fairly simple to install things like a hoist. I mean, or something like an aid. There's something, use
Oh,
that's
that's
quite
all,
common in
yeah.
supported living contexts and care homes. These aren't huge differences necessarily. I'm really sorry that you've had to experience that, and it just makes me reflect on, been thinking about it in a very global sense of how we can take these things for granted or they're not discussed explicitly. But it really brings home why this needs to be discussed and why it needs to be explored in its own right, and the practical and emotional impact it can have when you're rendered invisible.
And I think it's really important that people take on board that I think of myself as someone who's quite tough. Um, I have been described as students as a bit scary. I'm not a wallflower by any measure, but it's really upsetting. And I've really noticed the emotional drain of those kind of things, because it's just a constant message from the world that the world isn't for you, you don't belong, you don't count, you haven't been factored into how this space is designed, how this building has been created. We don't care about you. And it's a really hard, emotionally kind of draining kind of message to live with. The first time it really hit home was when I was going to a very lovely local hospital. Really, I mean, I have discovered that I like small local hospitals. They're much nicer and much less stressful. And I was walking across from the disabled space, and the drop curve was off to the left. So you'd have to do quite a long detour to use the drop curve, or you could climb up that quite high curve to get into the building. And I thought, and it was just this moment where I paused and I thought, okay, so the world isn't for me anymore. The world used to be for me, and then now the world isn't for me. That I'm over there. That's my kind of access point to the world. It's segregated, it's apart, it's separate, and it's an add-on, and it's inconvenient because for whatever reason I am an inconvenience. And it was a real kind of visceral moment of just looking at curbs and thinking about what that meant. So I don't know how you put that knowledge in people's heads, but I think you really need to see the world from the perspective of someone disabled, and obviously people are disabled in all kinds of different ways, to understand how hostile both the built environment and the human bits of the world in terms of human interaction can be really exclusionary.
And I suppose that's what we're going to be starting to think about, as in terms of, human beings and that interaction in health psychology. And the thing is that most people would not want to, would not want to think of themselves as being exclusionary or do want to do these things intentionally. So, if this is uncomfortable for people, it's meant, it's a good place to be. This is, important. This is a part of us showing that actually we do care. So can you talk to me a bit about the human interactions, and then we'll think about health psychology more specifically?
The worst instance, and I was with my friend who's very posh and very polite, but also very strident at the same time. And I think we were in a garden centre. It was ages ago. We were at a garden centre. I think it was buying vouchers for my dad for his Christmas present. And the woman behind the till was speaking to my friend, not me, even though I'd asked her the question. We both looked at each other as if to say, is this really happening? Is this stereotypical interaction that you have with someone in a wheelchair really happening to us right now? And my friend said, my friend asked you the question, not me. And the poor woman looked a bit, oh God. And so her next move was to come out from behind the counter and kind of crouch down in front of the chair. And it's like, I know you don't know what to do, and I know you're panicking, and that's fine, because it's understandable, because there's, no one gets education on how to deal with this stuff, but it just makes me feel awful. And I think that's my general sense of the world, is I'm greeted by panic. and anxiety and people just not knowing what to do, and it's exhausting. And it's like, I get it comes from a place of good intentions. I get that people don't want to offend or do the wrong thing, but try to imagine what it feels like where everywhere you go, the reaction people have to you is panic and anxiety. And it's just like, oh, it's exhausting. And the occasions where people handle things really well, they're so rare, but they're so good. I almost want to cry. Because it's being treated with respect, and you feel like a normal person again, even though what you're doing isn't kind of your normal or my normal in terms of. So one really positive experience was my friend and I went to. I'm not going to be able to remember the house, but we went to a huge Palladian National Trust house, and they had a stair climber, so they put you in a chair and it climbs up the stairs, and it's like based on military, like tank technology. It's quite something to watch. And the two women who did it were just lovely. They'd obviously been trained incredibly well, but they just handled it so beautifully. They they introduced themselves, they asked my name and my friend's name, and they said, it feels inappropriate to do something that feels quite intimate without knowing your name, and they kind of explained what was going to happen, and they kept checking in, and it was clearly framed as kind of, this is what we do, it's no trouble at all. And and it was just a really wonderful kind of interaction because they just did it so well. They made me feel welcome. They didn't make me feel like I was a burden or a source of anxiety. They just had a service. They knew how to deliver it, and they delivered it incredibly well. And that's, that obviously takes training, and that takes resources, and that takes money to buy things like a stair climber, but it can be done.
And something to think about for our conferences, for example, which we'll come to. But also I'm getting the sense of being valued and feeling like you belong actually in that space, and that being a really important aspect of your experience of being able to have more of those interactions. So you might want to cry more happy tears. So
I mean, it's sad that it makes you cry because it's so rare, right?
I know. I hear that. And then thinking about how psychology, if we're thinking about ableism being a systemic issue, it wouldn't be a million miles away to think actually our discipline can be ableist and how that might show up. So I wondered if there's things that you would like to elaborate on that. I'm kind of led by you, here.
One thing that I have expressed disgruntlement about on Twitter last summer when all the conferences were going on was the fact that the conferences had gone back to in-person only events. And people were posting lots of happy pictures on Twitter, which on one level were really nice to see, but on another level there were lots of people crowded together in indoor spaces and no one was wearing masks. And it just, as someone who had to shield during the pandemic because of immunosuppression, so lots of MS drugs, disease modifying therapies, suppress your immune system. So I got that letter from the government saying you must shield. So I have been very cautious. I still wear masks in lots of indoor spaces. And I expect better from psychology, but I particularly expect better from health psychology, because as a group of psychologists, and I wouldn't count myself as a health psychologist, although I have taught health psychology students from the day I arrived at UE in terms of research methods and EDI issues and so on, and have supervised various student projects. It's an area of the discipline that's concerned with health and well-being, and disability obviously falls into that. And it's just been a real sense of disappointment, even betrayal, that people with chronic illnesses, people with autoimmune conditions, and people who are disabled have not been considered when it comes to organising events like conferences and seminars and so on. And I want to hold up my hand and say, in the past, I haven't thought, I've organised loads of events, loads of seminars and summer schools, and I didn't really think through the accessibility issues because I didn't know, I didn't understand. I didn't, we certainly asked people if they had access requirements, but it wasn't in my calculus in a way that it would be now. So I think this isn't about individual health psychologists kind of beating themselves up, but it's about making sure there's a space within health psychology so people who have lived experience and who have expertise can guide everyone in the field, everyone in the discipline about what good practice looks like. And good practice to me, and I'm thinking about that principle in the ethics code and code of conduct around respect for difference. Respect for difference means respecting the fact that some people are disabled, some people have chronic illnesses, and our events should be accessible to them.
Yeah.
And that they should be able to kind of fully participate in them. And I'm really mindful that when I moan about this stuff on Twitter, I get lots of private DMs or private emails from people who are earlier on in their careers saying, thank you so much for talking about this. This is my experience, but I don't feel able to speak up about it. So I'm really grateful that you're kind of saying something about it. And that makes me feel really sad that people feel so scared and so vulnerable that they can't communicate what they're feeling and ask the field and the discipline to do better. So just to emphasize, that people think it's just me being awkward and difficult and moany, I think that there may be people that you're working with, there may be people in your team that have the same views and experiences than I do, but they're too scared to speak up. So to me, the best position is to assume that there's always going to be someone that's disabled or that's immunocompromised or has various chronic health conditions, and to try and plan for them being at the event, being in the room, and how you can make things as accessible as possible, and take pride in showcasing best evidence-based practice as well.
Yeah. And it doesn't surprise me, sadly, that people don't feel able to come to us to say these things. You can try and create avenues for people to be able to say these things. And that doesn't mean that they will necessarily trust you or have faith in you, and that's understandable because of the institution that you end up representing. And so how that affects, what has gone on before can affect, how you feel about coming forward now, and changes, trying to, I suppose the thing is that we may need to think about is, also reflect on, we've asked for wide social change when the pandemic started, and yet we also don't necessarily, if we look back at that versus how we are addressing things like the conference, it's something to reflect on. And I know that some of this stuff is perhaps not directly to do with the like under the control of the committee, but then what do we do about that? How do we address that in order to bring about change and facilitate change? So yeah, I appreciate what you're saying there.
Yeah, and I think that at an institutional level, there's loads of critiques of EDI work. As I love the sort of phrase endless distraction in inaction, but I think that we potentially at different levels of an organization have more flexibility and more freedom to push for change and to demonstrate what good practice looks like. And I think the reason why people are frightened to speak up is because they know there isn't that support at a senior institutional level, but there might be support kind of lower down, and middle managers can have a huge impact on work culture and work environment. And and can shield people from the worst of the kind of senior structures within an organisation. So I do think we should reflect on what it is possible for us to achieve, and that maybe we can create bubbles of inclusivity within broader kind of environments of hostility, and that might be a better approach than putting all our energy into kind of fighting kind of upper level powers.
So there's different strategies as well there, there's tackling the core, and then there's also creating bubbles of safety, which can also be quite important. And in terms of I mean, you know, for it's worth, you've not been the only person that actually at your level that has been affected with chronic with disability as a disabled person, and there's been other people who in the discipline have also been affected, no doubt. And as you say, it's hard to say that publicly, if and one of the things that comes to mind is, and this is not a question for you per se, this is more of a reflection, is what does it take for people to be able to say that more publicly?
Yeah, and I think what's kind of the attitude that's kind of developed that I hear all the time from other psychologists is, well, you have to do what's right for your health, so you have to stay away from this event. And that's the only option that's presented. It's not, okay, well, everyone a mask up, everyone a lateral flow beforehand, everyone, the building will be ventilated as well as being accessible in other ways. Now, that's not even on the table. The option is you go and you take the risks, or you exclude yourself. So what's become acceptable is, oh, well, we never see Victoria at events because she's got to protect her health. The second step, well, maybe if we all wore masks, and maybe if we did this, and maybe if we ensured buildings were well ventilated, then people would kind of come along. So I know that there are people going to things and they feel really uncomfortable, because those are the only two choices on the table: come along or stay away. And it would be nice, and I don't know, I mean, I know there are valid reasons why some people can't wear masks, but I live in a body that's incredibly inconvenient, and I do it all day long. Wearing a mask by comparison doesn't seem that much of a challenge. If I could spend the rest of my life fully mobile but wearing a mask, I'd wear a mask in an instant. Because it is, and the idea that masks are inconvenient or uncomfortable, I think I'd invite people to interrogate what their point of comparison is for that. Because if they're living in a body that's fairly comfortable, a body that isn't inconvenient, then I can see why masks feel that way. But if you live in a body that is really challenging and hard work and takes lots of essential maintenance and is painful and uncomfortable to exist within, by comparison, putting an N95 on your face just doesn't seem particularly challenging. So I think there's something around the psychology of mask wearing as well, that it would be great if someone could do some research on that, about what the barriers are. I mean, I think one of the barriers as well is that no one's doing it anymore, and people don't want to don't want to be the odd one out. So the only time I've seen people put on a mask is when they're in an inside space with me, and they see me wearing a mask, and they see whoever I'm with wearing a mask, and then they kind of, one gets slid out of a pocket or a bag and they sort of put it on, because I'm very visibly disabled, so I'm very visibly marked as potentially vulnerable to COVID. And that seems to be the only thing that I've noticed where you see people put on a mask. It's when they look at me and they think, okay, I don't want to kill the disabled woman today.
Also, that the other reflection that comes to mind for me is that disabled people can often be more vulnerable to COVID. We know that from the early statistics. 6 out of 10 people that passed away from COVID that initially were disabled. Also, there are other groups, underserved groups, that are more vulnerable to COVID as well, including people of the global majority, or if you like the other term, Black and Asian minority ethnic people. And there's other, groups of people with, experience marginalization who also may be vulnerable, but we don't know the data on that. So, this can also actually, if we do wear masks and we do address ventilation, then we can also make it more accessible and inclusive to other underserved groups who might also otherwise feel unwelcome, amongst other things.
Yeah, I think that's really important, and that highlights the intersectionality of issues, but also that something doesn't have to be overtly racialized for race and ethnicity to be important to it, in the same that something doesn't have to be overtly gendered for gender to be important. So I think that's why intersectionality is really important, but not in the sort of identity, I occupy all these different identities way that it's kind of become kind of watered down into, but more into looking at the structures surrounding particular experiences of exclusion and so on.
And is there anything else in terms of health psychology? I know that you work in more academic settings. Are there other aspects of health psychology where you kind of critique some of the ableism that you experience in particular?
I'd really like health psychologists, and this again is something I've tweeted about and got some interesting reactions, to think about how they do research and how they write about disability and chronic illness. It's not an exaggeration to say that I've never got through a health psychology paper on any of the conditions I have. So chronic fatigue syndrome, MS, I've just got so angry when I've read the paper. I felt so othered because it seems to have been written by a researcher that separates themselves out from the patient group and positions themselves as someone who would never be a patient. So there's something really implicitly othering in how the research is written, that the researcher kind of takes themselves out of the group of people that might become disabled, and is kind of magically someone who's just a researcher and will never be disabled, will never be chronically ill. And I realise that academics and researchers are not writing for the participant groups that they're writing about, ironically. They're writing for other academics, they're writing for practitioners or policymakers. But I do think research would be better if it was written for the groups they're writing about, or at least written with them in mind, and written in a way that acknowledges that not being disabled is for many people a temporary state. And I don't know what the stats are, I think about 40% when you're over 60 or something. So, a significant number of us will become disabled at some point in our lives. I really like the descriptor currently not disabled, because that acknowledges that the not being disabled is a sort of temporary, potentially kind of temporary state. And it seems to reduce some of the barriers between the non-disabled and the disabled. It acknowledges that it isn't hard and fast, that it's kind of, it's, you can cross back and forth across those kind of categories. So I really would like, when people are writing up research, to think about what it would feel like if they gave, so if they're writing about MS, what would Victoria think of this? Or what would a person I know, or a random person with MS kind of think about this? What would someone with chronic fatigue kind of think about this? And I know kind of PPI groups, kind of to some extent, they can help you think through those issues, but I'm also conscious of the way PPI groups have become this kind of indemnity kind of clause. Oh, well, I've got a PPI group and that makes everything okay. And I really would invite people to think through the limitations of who joins those groups. they're often middle-class white women who don't work full-time. I mean, I'm never going to join a PPI group because I've got a job, although I am a middle-class white woman, so they don't exactly need me. But also, there's rarely one analysis of something. And I think about that in relation to, apologies for saying the word, obesity research, because I've often on Twitter kind of complained to people about them using the term obesity or living with obesity, particular kind of formulations. And the researchers have said, well, this is what my PPI group like. And it's like, okay, but at the time I tweeted this, I think I'm not currently a fat person, but I have been a fat person for most of my life, probably was when I was tweeting about this. And I thought, well, I'm fat too, and I don't like that language. So you need to think about the fact that particular groups aren't unified. They will have different opinions. There will be different language that people use that will often represent more politicized and less politicized kind of takes on things. So, I see the same thing with language around kind of race and ethnicity, where ethnicity is used as a euphemism for race because people somehow think that talking about race is bad. I mean, this obviously comes from white people, so they use ethnicity when what they mean is race, or they talk about nationality and it's like, that's not what you mean. So it's holding and understanding that there can be different ways of talking and thinking about things, and that you've got to make a reflexive, thoughtful decision about where you sit and why you sit in that space, and what language that you're using, and why you're not engaging with, or why you're not using other kinds of terminology. And I think for most people, they just haven't given it much thought.
And I think that also it can be a bit of a minefield trying to find things find dialogue on these topics. So, for example, for me, the term person with a global majority has definitely resonated a lot more. I already discovered that term last year because someone I know was conscientiously looking at, different terms that people may use and which may be more inclusive. And thankfully there was a paper on this. That's the other thing I think, when you're from underserved groups, trying to actually have your voice heard, to be able to have that dialogue in the first place, really is quite difficult. And I wonder, and that's something that, perhaps we need more of, those kind of discussions and access to those discussions, as well. Can you give me maybe an example of some of the things that someone might think about in terms of language? What, like, for example, of like things that frustrated you and things that you probably wished were said instead as a starting point?
I think around disability, the main argument is always going to be person first versus identity first language. And every day on Twitter there'll be one non-disabled person arguing that it's person first, it's people with disabilities, that are 100 disabled people saying no it isn't. So I think it's important to understand the difference between the kind of social model and the medical kind of essentialist model of disability. So the social model emphasizes that disability comes from society. So what disables me is not the fact that I'm a wheelchair user, it's the fact that I live in a world where the built environment typically has lots of steps and no ramps. And if it does have a ramp, it has a ramp off to the side rather than as part of the main entrance. And that talking about people with disabilities, although some people do like it, so it's important, and it can often vary by kind of condition and different types of disability. So people with disabilities are often favoured by parents of disabled children, but I think disabled adults would critique that because they see that as seeing disability as something kind of negative and something stigmatizing, and wanting to kind of emphasize the person rather than the disability. And I think what disabled activists have done really well is say, well, disability isn't a bad word, it's just a neutral descriptor, it's just part of my reality, and I want you to feel comfortable with that,
like actually autistic, for example. I see some of these nuances in terms of discussions around people with learning disabilities, who that tends to be favored by families, whereas, people, learning disabled people, or how people identify themselves, that kind of was much more nuanced when I would talk to them about how would you like to me to talk to you about this. But then there was also the additional stigma and social exclusion that them felt, and the shame that could come with that. So with these kind of things, you really need to think about, where the other difficulty I found, like, sometimes, was that I did actually submit. So I did end up having a journal article published, and they had specific guidance on how to refer people around learning disability, and that's something that perhaps we need to think about as well in the field.
Yeah, particularly if it's, because often more mainstream guidance or guidance approved by particular bodies, the process of producing that guidance is quite slow, it's not up to date, so people often will wave around the APA guidelines, which include both person first and identity first language. But then people don't understand, and I'm just starting to learn, so I'm by no means an expert, the different histories around disability activism in the US and the UK. So historically, people in the US have used people with disability. They've used that person first formulation. In the US, people have used identity first. And because the history of disabled politics are kind of different.
Yeah.
But if you don't know that nuance, and you don't know why those different terms are favored in different contexts, then, what basis have you got for kind of making a decision?
Yeah. And that's that's the thing, is two things. Well, obviously you've got to start somewhere, right?
Yeah.
So it does help to actually read these things and learn, and not feel that you have to know everything. We're all learning, all right?
Yeah.
But also knowing that what may be acceptable at one point will change over time. This happens often, and it's about a bit like someone saying about washing the dishes. You don't just wash the dishes once and then best for the rest of your life. You wash the dishes on an ongoing basis. So this is something that we need to keep current with, and if you can do things like use mobile phones, and probably in the future holograms or something like that, then it is possible to keep up to date with these things, and probably easier in some ways to understand. Yeah, and that makes sense. And I don't know how this lands with you, but the idea of perhaps having a little section as a researcher to position yourself and your identity and where you're coming from in a paper could actually be potentially quite helpful as well.
Yeah, I think it's tricky for researchers. I'm conscious that I supervise a lot of counselling psychologists, and if they're disclosing things that are stigmatizing from a professional perspective, it's like, well, and sometimes examiners can be like, oh, there isn't much reflexivity in your thesis and you need more reflexivity, and I'm like, hang on, they're not confidential, they don't have the protections that participants do, so you can't really force people to disclose information. So I quite like a suggestion, and I'm not going to remember the name of the paper or the authors of the paper. I know one of them was Lisa Lazard, that talks about either aggregate it. So, and I've seen some really nice examples of this, particularly in I was writing a review of thematic analysis research in the International Journal of Transgender Health, where they aggregated the demographics. So they presented it for the research team. So individual researchers didn't have to disclose that they were trans or not, but they kind of presented it across the team, and I thought that was done really nicely. But the other paper I have in mind, they say, we'll talk about the context. You don't necessarily have to disclose personal information, but you can talk about the kind of context that informs the research and your kind of positioning within it. So I think in general, I want to know, but I understand that there are very good reasons why people might not disclose that. But I particularly want to know when researchers aren't a member of the group they're researching.
Yeah.
Because I think otherwise you're putting yourself in that kind of, elite kind of privileged position of the researcher, and I can do everything, and I'm entitled to research and write about everything. And it's like, actually, no, you're not. And I want to know who you are and what your credentials are for doing this kind of work. So
I think there's something that I reflect on there, and it touches upon self-disclosure. There's the aspects of myself that I disclose, some aspects that I don't, and that definitely resonates. Gives me a sense of relief actually about not having to disclose all the intersections I experience. But I suppose the thing that I reflect on as someone who has come from some underprivileged positions at times and privileged positions at others, um, that if you're from an underserved group, for example, doing a piece of research with an underserved group, it's often hard to get support within the academy. It's hard to be a member of a team, and you can often end up being, the lone voice on that because there hasn't been enough support behind you. And I suppose in that sense, we can say the onus is on us to do that anyway. But I suppose I would add to that, it'd be really helpful to have a team and institutional support, to be able to facilitate things like, disclosure from a team without really outing someone, for example, when it comes to those kind of characteristics.
Yeah, and I think if you are privileged, that's a way of harnessing that privilege for good to support people, that are othered in particular ways that you're not. That's something that you can do. I think there's a real reluctance to, that's not my experience, that's not my identity, therefore I have no entitlement to do research in that area. In some ways you're right about that, but in other ways, how can you facilitate and support other people to do research in that area? How can you use the privilege you have? How can you use the voice you have within your institutional space to kind of support that? So I think and there's a great paper by Erica Berman talking about access to counselling, where her basic argument is if you use the argument that black women need black women counsellors, and there's no black women counsellors around, it effectively means a black woman client gets no service.
Exactly. Yeah.
So how if there's no one around to do this work, then it's better that someone does it than no one does it.
Absolutely, yeah. And I would say that within the field, say learning disability, the amount of barriers that people would have, that people have to be able to participate in research is just so much there, and hopefully that can be a bit of a bit of being adjacent and working with and walking with people genuinely and thoughtfully makes a big difference. And of course that does take resource, and would love to have more support around that, but it can make for much more interesting and useful of dare I say it, research with people if you do that with them. Thank you for that. Are there other things that you would like to see change, that come to mind for you? I know that we've been talking about quite a lot of things.
A slightly flippant thing that I'll just mention, that I've mentioned a lot on Twitter, is to not email people and say, I hope you're well. That's something I get every day, and my reaction is, nope, never will be. Thanks for that. Thanks for that reminder. And it's just another mundane way in which kind of ableism is kind of woven into our language, our kind of everyday normative kind of communication. So I've got on my email signature, the first line is a blog post that I've written explaining why that's problematic, and it sort of slightly amuses me how many people just never notice it and just keep sending me emails saying I hope you're well, and then people that have noticed it and do these gorgeous balletic email kind of maneuvers that avoid saying anything remotely kind of problematic, and you see that they're putting a lot of work into it, and you think, I really like you for that. I really appreciate the effort that you're making with that. So I think that's something really important that for us to reflect on, the mundane ways in which we privilege and idealize a well body and a non-disabled body, and that in health psychology as a field, that's really something that we should be thinking about a lot. And obviously there's lots of fear and anxiety around disability and illness. And I think if we're able to sit with that fear rather than try and ward it off.
Yeah.
That,
funnily enough, I'm thinking about this from a slightly different perspective of how many people with chronic illness or chronically ill people work with or do research with other chronically ill people, either the same conditions or others, and just thinking that actually if we did let go of that assumption or make it easier to challenge that, then actually it can make it a lot easier for those people to openly identify themselves with that, and that and it is another way of things like making events a little bit more inclusive. It's and certainly notice sometimes perhaps well-meaning people when I have been to conferences before who have made ableist statements, and thinking about actually how we might need to physically draw up some guidance around these are some of the things that you need to think about not saying, because you cannot assume that this will apply to everyone in your audience, and it can make people feel really othered, even if, and I've witnessed this, even if they are used to it, then those people who are around them who may know their circumstances can end up also treating them differently, and that, so it causes a bit of a ripple effect, what I've witnessed.
yeah.
Yeah.
And I think it's people assume if you don't react that you think certain ways about things. It's like, no, all the reactions are happening internally. I'm just not sharing them because there's no space for those reactions to happening. Doesn't mean I'm chill. Doesn't mean I'm okay with it. Doesn't mean I'm relaxed. I'm actually fuming inside, but there's no space here for that. So yeah, I think it's you don't really know what's going on for someone unless you ask them and they feel comfortable kind of sharing that with you. So
yeah, definitely. Oh, I mean, yeah. Anything else that I've missed or anything? Okay,
no,
well,
I think that's enough for people's situation.
And also, we often invite people to share things like articles that they so feel free to do that, anything that you might find of interest, and thank you so much for this and for your time. Really do appreciate it.
All right, you're very welcome. It's good to be here.
Thank you so much for tuning in and listening to the conversation in Equality, Diversity and Inclusion in Health Psychology. My name is Dr. Jeremiah, and I will see you next time.